Thank you. Dear ladies and gentlemen, good morning. Thank the committee for inviting me for this presentation. And of course, I thought they challenged me by giving me the title Dutch Courage, which of course in London I can't let go, referring to what actually for Englishmen is Dutch courage, is going into battle after intoxication yourself with alcohol. But you don't know, as English, that it's just business, because Willem of Orange, the guy on the right, top on the right, promoted the use of Dutch gin or Geneva. And actually, it's the starting period in the UK is called the Glorious Revolution. So I do think it's still present. If you go into the social media, you still find it that it's appraised in the UK to get some drinks and do your work. And I must admit, I haven't had an alcohol this morning. Sorry. But for me, as a Dutch courage is actually the one that we made and get the riot on the Medway, where we smashed the English fleet in the Medway where they were harbored and took away the flagship of the Royal Charles and took it back to Amsterdam. But of course, the Netherlands have also Dutch courage in keeping up our sanity of a weed. And we do have experience how to treat bacteria and fungi so they can't battle our weed production. But having said that, the Netherlands is a very small country, so I have to talk about the real world implementation. And here you see the 8 academic hospitals who perform actually the high care of the hemat-onc patients. So we did a survey in 2012 where we asked, do you adopt still fever-driven management of patients with fungal diseases or suspected of fungal diseases? And actually 7 of the 8 centers did not. But if a patient persisted on fever and you have no clue whatsoever, and you have no biomark assays to your availability, would you then go for a diagnostic approach, or would you go for changing into antifungal therapy? So, and again, in 2012, you appreciate that, 7 of the 8 centers still continue in a diagnostic approach. But at that time, they didn't recognize the azole resistance in their decisions. So work done by the Erasmus, and I believe that Alexander Schouwvliegen is already here. I don't know if he's already, yes, he's sitting there. So he performed a survey of the Dutch academic centers and asked, what do you adopt for prophylaxis? And actually none of the hospitals adopt azole primary prophylaxis in intensive treatment for AML or high-risk MDS or in the allogeneic stem cell transplant. They do use azole prophylaxis in the context of GVHD treated with high-dose corticosteroids. And that may be a bit different. You can see most of the time it is indeed voriconazole, but some use itraconazole or posaconazole. And the ones with itraconazole, you will notice they will pop up. It is always the same hospital. And I just put it as very small. It's about the Leiden Hospital. But after having said that, the survey also inquires about diagnostic strategies that is adopted by those centers. And you see almost none uses the galactomannan survey. Only we have a regular monitoring of galactomannan in the blood for these high-risk patients. But all perform a low-dose or high-resolution in the past CT scan in case of a refractory fever after broad-spectrum antimicrobial therapy in a suspicion of invasive fungal disease. And they move on into bronchoscopy and try to get the BEL. And if the BEL is succeeded, they go for galactomannan measurement. And some of the hospitals, only the minority, who have in-house or a commercial PCR, perform PCR testing of the BEL fluid, searching for an aspergillus content. So, and then if they try to maximize the diagnostic strategy, how would they perform in treating? And that is still with voriconazole in all of the centers. But it depends on the clinical state of the patient. So if the patient deteriorates, some of the centers will switch then into liposomal amphotericin B, or they wait about the results of the galactomannan testing of the BEL. and then decide if the BL is impossible, then they switch to liposomal amphotericin B, and otherwise they wait for the Galacta-Mannan results coming up. But in case of a positivity, but not able to get a PCR, what will then be the procedure? If a patient is still stable, they continue giving voriconazole, but if they are critical ill, they tend to switch to a coverage of the non-Aspergillus molds. And if resistance is detected, all of the centers will switch to liposomal amphotericin B. And this results will shortly be in a manuscript to be published. So, now what about the Dutch courage then in Nijmegen? We use a high-risk stratification you all are familiar with, and tend to get a non-empirical approach directed to those patients who get high-risk AML, high-risk MDS or AML and allogeneic transplant. And we perform a simple strategy that we test for Galacta-Mannan twice weekly, and if that is possible, we move on to a CT scan, and if there are abnormalities, we move on to a BEL, or try to get a tissue, and then if the tissue is any of these tests is positive, we move into, this is very hard, we move up to antifungal therapy. If the Galacta-Mannan isn't positive, but there are clinical triggers like refractory fever or a positive culture in the sputum, we move indeed the same structure of CT scan, BEL, and try to get tissue, and then decide on to start antifungal therapy. But in case of a negative result, we withhold our antifungal therapy. So, of course, there's a discussion about cutoff values to determine sensitivity and specificity or positive or negative predictive value in your specific population. We determined on the basis of a consensus that twice a Galacta-Mannan sample of 0.5 or 1 or above 0.7 is to start the diagnostic workup in our center. And also the clinical triggers is assigned to start up our clinical workup in case of performing a CT scan. And when we used the bronchoscopy to get the BEL, we had a consensus about the cutoff level of the BEL to be used in case of Galacta-Mannans being found, and we said 1 or above is used as a positive sign to move on. And it is to press the fact that this is done in the context of no primary azole use. So we adopt, of course, it's prohibited, but we do adopt the revised consensus definitions for proven, possible, and probable invasive fungal disease, making use of the host factors, the clinical features, and mycology. And we try to categorize the abnormalities we've seen on the CT scanning. And there are a lot of consolidations, nodules, micronodules, micronodules, atelectasis, effusion, and other signs of invasive pulmonary disease. But the classical ones are the well-circumscripted dense lesions with or without a halo sign, an air crescent sign, or a cavity. And these are used to identify the cases of possible fungal disease, especially those who are aimed at Aspergillus. So we use in our center these kind of classifications. Host factor, clinical feature needs to be specific for Aspergillus in the context without azole use, and classified as impossible, or if we have direct or indirect mycology results, and classified as a probable, and start voriconazole. And in the past, we start itraconazole before voriconazole came around. And then you can say, of course, but what it really happens? So Bram Lestrada, a microbiologist, did research of the Nijmegen audit of azole-resistant aspergillosis among patients at high risk of invasive aspergillosis. And it is recently published in GEC. And the objectives of this audit was to estimate the occurrence of possible, probable, or proven invasive fungal disease at our ward from the years 2006 till 2012. And we included single patients, so no single episodes, but single patients. And we aimed at neutropenia, so it is aimed at the remission induction courses or consolidation courses for patients with AML, MDS, and of course those treated with preparative conditioning regimens for stem cell transplantation. We took a laboratory's work to get all the data out of the clinical records, transformed them in a clinical record form, and looked at the underlying disease, neutropenia, radiology reports, microbiology reports, including BLL and biopsies, the antifungal use and reason why they were started. And each patient was followed up for 6 months during that cohort of analysis. And then every case was reviewed by 2 persons. And in case of difficulty, our Nestor of mycology research, Paul Verwey, would have the last word. And then the database was closed, and we had a look. And we applied, as I mentioned, those revised definitions, and look into the frequency of the recovery of fungal positive cultures, and especially aimed at resistance and triazole resistance. And also we took the 180 days, or the 6 months overall cause mortality in this kind of patients, and looked at the impact, if you could get some impact of triazole resistance on that. Showing you some results. So at the end, we could include 432 patients. Most of them were allogeneic transplant, 58%, and the others were AML. And as you can appreciate here, that the normal characteristics, so there's some older patients, predominantly male, and in the AML, 90% had AML, so 10% MDS. They were profound and deeply neutropenic in almost 80 to 100% of the cases, and the duration of neutropenia was more than 40 days. And most of the AML patients got a remission induction course. So the very high-risk patients were included, and half of the transplant patients received a myeloablative conditioning regimen. And if you then look into what really was diagnosed, then only 4 patients were diagnosed with improving disease, so only 0.9% of the total cases. The probable 13 in AML MDS and 19 in the allogeneic transplant, and possible 10 more, 23 and 11. So meaning that 83% at least had no invasive fungal disease. When we look back to the BLLs, we did a lot of BLLs, more than 250 BLLs were performed in that cohort, but restricted to a BLL done within 1 week after performed CT scan in the course of fever during neutropenia. We came out with around 97 combined results, where we looked into the specific features of the CT abnormalities, as I mentioned: tree and bud, ground grass, no halo, halo sign, cavities, nodules, micronodules, number, size, and aspect. And what you can see is that most of the CT show no micronodules. A minority does have some nodules, but they are less than 10, when the nodules are increasing of 1 centimeter. What was striking was when you look back into the positivity of the ball, determined by either a positive PCR culture, microscopy, or galactomannan, then you could see in the group who had a positive BEL had far more halo sign on the CT scan, twice as much, and in those who had a negative ball. So halo on the CT scan indeed is indicative of invasive fungal aspergillosis in this setting of patients. But of course, what amount of specimens did we try to get out of the lungs of those patients? So we did a non-sterile 687, of whom we recovered 45 Aspergillus fumigatus with a percentage of 6.6%. And 2 of them were fluoroconazole resistant. And if we look into the tissues and the sterile specimens, then you can see that 126 specimens were obtained, where recovered Aspergillus only in 2, and none of them were resistant. Combining these 2, you get 830 specimens, where you have 5.8% showing Aspergillus fumigatus, and showing that 28 of them were resistant. But looking into the 28, then azole resistance came up with 5. So 5 out of them came, so 79% in that specific group became resistant. So all of these kind of interpretation depends on the denominator that's been used to classify these patients. So if you then go back into the 2 original cohorts we had, in the AML-MDS, you can see that 141 had no invasive aspergillosis, according to the application of our revised definitions. And in those patients, 179 attempts were made, and indeed, one culture was positive and one patient was positive without resistance. So you can look into the other tables for the possibles and the probables, but what in the proven ones you see only 28 attempts were made, 5 positive cultures in 2 patients, and 1 was triazole resistant, but not resistant for voriconazole. And if we look into the ALO cohort, you can see on the right, indeed, the ones who were not diagnosed as invasive aspergillosis. We had 371 attempts, and culture was indeed positive in 21 of them, in 12 patients, and triazole resistance came up in 3, and 2 of them were indeed voriconazole resistant. So if we then look into the specific recovery of the voriconazole resistant samples we took in the proven and probable group, the 36, then 12 of them came out of sputum BEL of biopsy. And, but also 13, so 3.3% came in the non-invasive aspergillus group. And also in that group, 3 of them were triazole resistant, making up an incidence of 1.2%. So actually very low. And the voriconazole resistance of those cultures was absent in the group on the right. So what about then the implications that might have for all-cause mortality? Put on day 180, you can see that if 55% of the AML cohort after 6 months was deceased, and that was 46 in the transplant, making up 50% for the total group. They're only due to invasive fungal disease in 10 patients. But if you look in those who experienced probable or proven, they had a twice as high rate of mortality with respect to the non-invasive fungal disease group. If you look at then into 5 positive cultures for triazole resistance, you do appreciate that the mechanism is not always the tandem repeat mutations we know, but in 2 of them it's not diagnosed. And also you can appreciate in this table that the invasive aspergillosis and the resistance of that aspergillosis, as I mentioned, was also diagnosed in 3 of them in the non-invasive aspergillus group. So making it very hard how to apply these criteria in daily clinical practice. Would you say what happened after 2012? Well, then we moved into participating in this big therapeutic phase 3 study as the only Dutch center, and we adopt a strategy to include the patients with AML, the same high-risk patients and transplant patients, into strategic study headed by Peter Donnelly, which we very much want to know what the results are. Maybe that Johan can tell a bit more about that. Where the patients were randomized between 2 arms, an empirical one and a diagnostic-driven one, actually using the same criteria as I showed you before in our NARA analysis. And after the trigger, patients were treated with caspofungin. And one of the primary endpoints was all-cause survival or all-cause mortality. So what should we do then now in the era of popping up voriconazole resistance in the Netherlands? This is a recent report showing that, but I have to warn you about the denominator that has been used, that there are increasing rates of voriconazole resistance depending on different centers, different wards, and different locations in the Netherlands. But it prompted the Guidelines Committee of the Dutch Working Party for Antimicrobial Policies to have a very firm recommendation, stating namely that in patients with invasive aspergillosis caused by isolates with unknown susceptibility to azoles, initial combination therapy with fluoride or isofluconazole plus liposomal amphotericin B is being recommended. We had a lot of discussions about that, but it's still in as an important recommendation. So the whole of Netherlands is now being fussed about this. So that's I think, a good initiative of a guideline, starting the discussion after you have put the guideline. But anyway, there is an escape in those centers who are able to use resistance analysis to look into mutation-associated resistance of fungi with different kinds of PCRs, either in-house or either commercial, where you can start up your analysis, await the results, and then switch in case of resistance to liposomal amphotericin B. But we really want, and I do recognize that at the end of the whole, you don't see what's on the slide. It really doesn't matter, but basically we are back to our initial adoption. So if we have suspicion of an invasive fungal disease, we agreed on in all 8 academic hospitals to move on together in a prospective registry to get these patients followed up properly. We will continue starting with fluoride, isoconazole, or in some center posaconazole, perform a BEL, have a cutoff of 0.7, and then try to get results. And in case of a wild-type wild-type aspergillus, we continue fluoroconazole, and only if the results are dismal in the sense that you have indications of azole resistance, move over to liposomal amphotericin B. And in case where you don't be able to perform your BEL or the results are inconclusive, it's up to the incidence in that center. If you have an incidence above 10%, some of the centers will continue and switching to combination therapy or to liposomal amphotericin B, depending on the mold that they are aiming at. And if the incidence is below 10, we will still continue fluoroconazole. So as I said, all the academic centers participate in this AZOMAN study, so azole-resistant management in the Netherlands, and we hope to get results in about 2 years. I'm all at the end of my presentation, and I want to thank Samuel Pepys, and I have to pronounce, still does in all things, in wisdom, courage, force, knowledge of our own streams, and success. The Dutch have the best of us and do end the war with victory on their side. Many thanks, many thanks. But the really people I want to thank are those who did actually all the work, especially Bart Reinders and Alexandra, and also Bram Lestrade, Elisabeth de Kort, Walter van der Velde in the Netherlands. And thanks to Peter, who guided us through all this. Thank you.